were almost nil. The Abbey study with Stampede T4, T3, T4 were not defined because defining T4 itself is a bit difficult. But we have seen in GG5, T4 are about 15%. In POP-RT, about close to 10% of patients are T4. So we have, as I mentioned, this is the group which we have already, and we are trying to brainstorm few ideas. And we were thinking of defining T4 on MRI and PET and CT, random image reviews if feasible, because I don't think central imaging review of the T4s will be possible and feasible. Non-metastatic on conventional imaging or PET stratified into T4 due to bladder involvement, rectal involvement, or others or both. And all patients should have received radical doses of radiation ADT and treated with IGRT. I think the strength is most of the centers which we are part of. I mean, the group is part of our practice IGRT routinely. Then we are trying to develop the CRF form. But as I said, this is just a few slides to put it in front of you to initiate a discussion regarding what all we can think about. I think I'll float a few ideas, and based on that we can have a discussion. It's like a more of a panel discussion where I would be asking you some of you few questions, I guess. PET is our strength, IGRT is our strength, SBRT is being done routinely. So could we have some ideas from the audience? What about T4, by the way? T4 lesions? Any of you have comments? If you are urologists, you can also pitch in and give us ideas and suggestions, because those would be helpful as well. I think.
Sorry, the T4 one, I would probably leave it because it's a radiology-based one. But what I realized is the amount of neuroendocrine differentiation that we tend to pick up in Indian population is a lot more.
Yes.
And any trial that is published, they almost don't even look for neuroendocrine, at least in the primary de novo setting or in locally aggressive prostate cancer. And as we are anyway, all Gleason 4 or 5, we are doing neuroendocrine.
Right.
It would be useful to just study that as a subset.
It's a
whether
very
they
good
go for surgery or whether they go for RT and say, what happens to these people?
Yeah, neuroendocrine as well as ductal adenocarcinoma, we do see a small proportion of us see ductal adenocarcinomas as well. These are variant histologies which probably need some data. That's a very good suggestion.
Post-URP setting is another area where we have to, because we are concerned about structuring that part, and you are concerned about incontinence in our side. So this is one way, by quality of life or something we can assess. That is one area where we have to do something.
Post-ERP is a very good point as well, but it has been seen across a few studies now from India. That post-ERP, Dr. Gupta also mentioned regarding whether it would impact the outcomes, which is a very interesting point. But we were mainly looking from the point of view of whether TORP would add to the toxicity, which it did not, in the context of SBRT as well as moderate hypofractionation. But TORP point is well taken as well.
While we are talking about the grade group 5, I think he brought on the point that neuroendocrine. But FDG PET scan would be an additional investigation there, and molecular studies.
Yeah. And of course, as I said, when we mentioned of these neuroendocrine, we'll have to look at comprehensively what imaging is used at the staging and everything else. But I would like to request Dr. Allison, you've been hearing the talks very patiently for the last 2 days. Sometimes we need an outsiders and that too from a person like with such huge experience in research. What would be your suggestions for us in terms of research?
Thank you. It's been a fascinating meeting because the population you treat is indeed different, and I think you quite rightly are putting a lot of effort into getting India-specific data. And so just my observations from looking at the data you've presented is that you have a real opportunity to lead the world in terms of the higher risk prostate cancer, node-positive prostate cancer, and answer the questions that we can't because we see much earlier disease. So that would be the obvious opportunity from my perspective.
Thank you. Dr. Nagar, your suggestions as well? Node positive and high risk, of course, if there are any specific suggestions to make in those cohort of patients?
No, I mean, I think what's being done is excellent. Just to echo Dr. Tree's point, is that right now it's, running the trials that are necessary for these patients, collecting the data, and then also, there's a big, while randomized controlled trials are the gold standard, but just the real world experience and real world data which India can provide the rest of the world, just because of just the sheer number of patients you have here, even if it's just a cohort study, will be very informative, not just for surgeons, radiation oncologists, but also companies that make drugs that could provide resources to fund these studies may be helpful, because we know that especially in a higher risk group, the systemic therapy is going to be very important, and then you can lean on industry to help support some of these efforts. So I think getting data set to push them to fund further research is going to be very important from a feasibility and having financial efforts dedicated to this.
Thank you. Indranil, I want you to say, in fact, I was about to invite you. Of course, Indranil is leading many studies at the Tata Medical Center. But after your comment, I will also have a question for you that what can you think of PSMA PET? Yesterday, you presented a very well. What can you think of PSMA PET, and how can we leverage the amount of PSMA PETs we are doing in before radiation, in many different settings?
What I was going to say was that we are still collecting data in silos. We are collecting radiotherapy for T4. Actually, what we should be doing is we should be collecting T4, all comers, whether they're getting any local treatment or not, surgery, radiotherapy. It's only then can we really answer some questions, because otherwise it's limited. And SOGO does provide, therefore, a platform where the surgical data and the radiation data can be captured together.
Of course, it is easier said than done, because
it's easier said than done.
Yes,
No doubt about it. But it should be a goal to at least in one site.
Yes.
See, it could be node-positive prostate cancers.
Yes.
It could be, in terms of PSMA, I think that, again, I think that it's very difficult to do randomized control trials, prospective studies, but we should actually encourage prospective data collection, which means that if through SOGO or whatever, we say that whatever is going to happen, these centers will collaborate. All the results of the PSMA in various settings will be prospectively collected. That will actually add a lot more value, because you're then not chucking out patients who did not come for follow-up. You will realize how many patients don't turn up, the dropout rates, etc., which actually never gets reported. We are only reporting patients who nicely completed SBRT.
Correct.
But what of people who didn't? Yeah. So those are the things.
Thank you, Dr. Srinivas Chilukuri. We now move on to the next topic, which is newer age technology in oncological horizon. We've got 3 speakers. Each speaker has 7 minutes, and followed by 4 minutes of discussion. We have our first speaker is Dr. Ashwin Tamhankar, who's a consultant uro-oncologist from Dinanath Mangeshkar Hospital, Pune. Sir, your 7 minutes will start now.
Thank you so much. So with this, I would just say change is the only constant, and that stands true for the designation as well. So scope, when I look into the future, what I would want for my patients is I need to choose my candidate better for deciding about the therapy, optimize the surgical outcomes. For surgical training purposes, going forward, I would have my fellows, so I would be having a perspective on that as well, and then a tailored follow-up to an individual patient. That should be the goal. So the topic is too broad. I'm just trying to cover up upon 4 or 5 points. Let's try and see how much points we can cover in the stipulated time. So radiomics, it's coming in a big way. Definitely underutilized in India. Probably there should be more radiologists in this crowd. That can be a goal for the next Sogocon. We involve more radiologists who are dedicating their times in uro-oncology as well. So it differentiates oncocytomas, benign AMLs from RCC. Definitely a good pointer. Variable grades in the RCC, which helps us for some decision makings, and subtypes of RCCs can be. Just a quick example, we all have these kind of examples. Unfortunately, they are not that reported or not that spoken about that often. So a high risk mass, 9 centimeter renal, 12 score, undergoes lab radical nephrectomy, and biopsy turns out to be oncocytoma on the final histology. So if radiomics would have been utilized regularly, probably there would have been a caution statement coming from a radiologist, and I would have attempted a difficult open partial maybe. So that's the small change in the SOGO data. Luckily, Raghavan sir mentioned about 10% still in India we have benign histologies on the partial nephrectomy. So that is one underutilized segment, at least for now in Indian context. Regarding the grade of RCC, probably that will also help us for deciding lymphadenectomies. A grade 4, if it is speculated earlier on the radiomics, probably I would err on a side of a massive lymphadenectomy at a little small size of tumor as well. So next is similarly, radiomics is coming up in a big way in prostate biopsies. Though all of us know that yesterday Dr. Gagan Gautam mentioned about 2 + 3, 5 Gleason score. So we get those examples in India. So it has to be a standardized reporting, and AI probably would help us. Similarly, there is an inter-observer variability in the radiology section as well. So decision makings for the biopsy, PIRATS 3 especially, these are the ones which probably help us for deciding if we embark upon a strong radiological support in radiomics. Coming to the surgical part, one good part is complex partial nephrectomy. Acknowledgements to Raghavan sir for few slides here. So tumor character, what I am supposed to say into that complex tumor identification, tumor characteristics, the nature, hilar anatomy, and the vascular anatomy. This will solve the mystery for me to have a little safe surgery, being very honest. So the inner site has been utilized. Yesterday we saw almost 3 speakers incorporating this particular segment into their slides. So that means it has been utilized commonly in India, unlike the last year when only few people were utilizing it. So these models can be 3D printed models or virtual models. So 3D printing models will give some hyperaccuracy models, and they are more for patient counseling. Pitfall is more expensive nature, more time consuming, and there is a possible deformation. They are coming up with some 4D printings as well, so the future is bright there as well. Virtual remodeling, obviously it's an interface which is interactive. You can add or subtract some locations and lesions, and then you can potentially have some decision makings. It needs good expertise, and the future in there is artificial intelligence and a real-time navigation. Just a quick video. This is again coming from Raghavan sir's side. I am yet to use this, but looking at these videos, probably potentially we should all use this. So upper polar renal mass, stretching the pancreas, splenic vessels anteriorly. If I'm not very particular in evaluating the 3D anatomy of this particular context, I will still try and go in transperitoneal approach, but which probably might injure splenic vessels. So open retroperitoneal approach would probably do a better justice here. So it definitely helps us for identifying our approach: robot versus open, radical versus partial decision making, transperitoneal versus retroperitoneal approaches. It also helps us for identifying or dealing with endophytic tumors or multiple tumors. And ultimate goal is obviously trifecta and pentafecta. If you want to add ICG to the 3D printed virtual modeling, probably that will be a cherry on the cake that will lead to some selective clamping, minimizing the ischemias, and obviously the long-term goal is pentafecta outcomes. That's been seen in the trial. It's not a trial, obviously, it's a retrospective series, but all the parameters or the boxes have been ticked in that particular segment of cohort of patients where it is utilized. The next step after that is holographic reconstruction and integration, and that is incorporated during the live surgery in a tile pro sequence. The Chinese group is definitely, they have published some papers on this. If there are certain representative images in which you would want that kind of situation happening intraoperatively. Given a scenario, if everyone has this facility available, everyone would want to embark upon it, then why not now? So a tumor which is stretching the renal vein, there is a small artery which is running ahead of the tumor, which you know that if it is going to be there, you clip it, you are going to save the kidney. Invariably, if it bleeds, the kidney is going to be lost. So these are the things which we need to utilize more often, and the data says that it gives better opportunity in terms of overall recovery. So practice before you play. So that stands true for training. For a complex partial nephrectomy, for all of us, it's something which is desirable. But for a straightforward mass, for a trainee, if you're trying to train him for partial nephrectomy, which we all must do going forward, if he can virtually practice that particular thing a day prior, that will definitely help us. So these are the things which are going to be important. The second part, which I'm going to cover in next 2 minutes, is confocal microscopy. It's a fresh tissue biopsy. So it's a biopsy ultimately that is run with the lasers, and it similarly gives similar to H&E appearance of tumors, and gives you some concordance. So Bernard Rocco group kind of conducted these studies, and the concordance is about 97%, which is a huge concordance on the periprostatic tissues. So 2 indications again for prostate. Biopsy wise, you can actually have 95% concordance. I'll just take this one step ahead. We saw a German paper last few months coming up without a biopsy undergoing a prostatectomy. Then why not utilize this segment, do a biopsy intraoperatively, try and have confocal microscopy, and then do a prostatectomy in the same setting without waiting for 4 weeks. A potential food for thought, though cost is going to be a hurdle, obviously. One caution point about confocal microscopy, that in vivo it is a less feasible option. So ultimately you have to take the specimen out of the body of a patient, either a periprostatic area or the entire prostate. So again, the NeuroSafe technique, which is highly dependent on the extremely good pathologist, can be potentially replaced here. And the advantages are less of learning curve, a stipulated nomogram related appearances, and good concordance to the final pathology. Last two things quickly. So augmented reality has been actually utilized for prostatectomies with 3D printed models, and then it is actually utilized with a tile pro sort of imaging during the live surgery with high fidelity and precision 3D reconstructions. That's been discussed. And one last point on PSMA guided therapies, which people are also utilizing for, especially for salvage setting, when you have a node which shows uptake, potentially can be picked up with the PSMA therapies. And that's my concluding slide. So one good part on the remote monitoring. So that is one thing which we are missing out upon. Our patients, especially in Indian context, they go back and you're just, basically we are relying on a principle of no news is good news, but probably the future should be that you should be having a good reporting of tachycardias, perioperative problems, fever profiles, and that can be done with some the technologies. The IROC trial actually utilized a Fitbit device in the context, and even the Razor trial also utilized some exercises which were monitored in the perioperative phase, the second part of which came up with. So that's one part for monitoring purposes. I think I'll end here. Thank you so much for the opportunity.
Thank you, Dr. Ashwin. To present the radiation oncologist view, I would like to call upon Dr. Himanshu Nagar, who is a faculty from Weill Cornell Hospital, New York. Over to you, sir. 7 minutes. Thank you.
First of all, thank you for the opportunity and the invitation to speak. I think we can all say this has been an incredible meeting and an incredible learning opportunity for many of us here. So I've been tasked within the next 6.5 minutes to convince everyone here why within the next 10 years you're going to be talking about MR-Linacs for prostate cancer radiation treatment, and words like protons, CyberKnife, and CT-based treatment are just going to be vernacular and considered the past. These are my disclosures. So today we're going to go for the rationale of MR-Linac for prostate cancer, followed by our workflow at Weill Cornell using the MR-Linac. We'll touch on MR-Linac trials in localized prostate cancer, and then trials in the postoperative setting. So what's the rationale? So we've seen there's an incredible imaging revolution in prostate cancer. So some may remember this is how we used to treat prostate cancer, looking at a plain film and sort of putting a box around the prostate.